Hi, my name is Colin Bucks. I'm an emergency medicine physician at Mayo Clinic in Rochester, Minnesota. It's my pleasure today to talk about prior outbreaks and the lessons that we can take from them as they relate to COVID-19 now. A bit about me, my past experience. I've been a physician actively involved for about a decade with health system disaster preparedness. I've been a FEMA urban search and rescue physician, and after becoming a physician, became a U.S. Forest Service firefighter. I've been involved in a number of international humanitarian responses, including care for patients with Ebola in Liberia. Today, I want to share some reflections on the evolving COVID-19 outbreak. I want to take anecdotes from the past and share these and hopefully draw analogies to where we are today. And at the end, and potentially controversially, I'll provide some recommendations and resources for preparing your health system for what we're facing currently. Now, to begin with, I want to provide some reassurance. As much as there's a whole lot of uncertainty and changing dynamics on a day-by-day basis, one thing that I take solace in is that we've run this drill before. We've prepared for other outbreaks, particularly over the past 2 decades. In 2002, 2003, we had the SARS outbreak. 2009 and 2010, most of us went through the surge of H1N1 influenza. 2012 saw the emergence of MERS-CoV, another novel coronavirus. Currently, the Democratic Republic of Congo is still undergoing an Ebola outbreak. And certainly, I think most of us can remember all the time, effort, dollars invested in preparing for the Ebola response in 2014, 2015, when that outbreak was occurring in West Africa. Shortly thereafter, we had a mosquito-borne outbreak, the Zika virus. In 2017, we even saw the reemergence of plague in Madagascar. So we have a new novel virus, but this is not a situation that's entirely new to us. We've got lessons to draw from, and we've got preparedness efforts that should still be in place. Each outbreak follows a similar pattern. First of all, before a new virus or new agent emerges, there are preparedness activities and surveillance. We're better off when there's early detection. It seems potentially that this virus was emerging in the middle of November of this year, but we had the alert that something new was occurring at the very end of this past calendar year. It's fascinating, and one of the differences this time is that we had the genetics released approximately 2 weeks later, an astounding timeline. Once we have early detection, we can start defining what the case definition is, identify the cases, create systems for isolation and contact tracing to start wrapping our hands around the scale and scope of the infection. Admittedly, this is harder in a world connected with rapid global transit. Still, this outbreak has been helped by the massive quarantine and travel restrictions that were placed by the Chinese government early on. After a new outbreak has been detected and containment has begun, then we begin the control and mitigation efforts. This involves expansion of testing, implementation of broad-spectrum, wide-ranging infection control procedures, and developing advanced treatment options and, in time, vaccines. Outbreak eradication comes with time and with huge effort. And then one step that is often kind of forgotten is system recovery, both for populations and for our health systems. So I want to talk very briefly about Ebola because it was near and dear to my personal experience. Ebola occurring in West Africa. Much of this was urban, much more so than prior outbreaks, but a fair degree was also occurring in the rural areas of West Africa. We found that some of the best containment and best care could occur if we developed dedicated treatment facilities with dedicated teams that then allowed cases to be removed from the general hospital population. The priorities in these Ebola treatment units were staff safety, keeping everybody in tune with and absolutely dedicated to infection control procedures, breaking the chain of transmission, and that is identifying the patients, getting them safely isolated, safely tested, and providing the highest level of care. That outbreak, the majority of that was supportive measures, allowing the body to fight off the infection itself, keeping them strong in between. But now there are actually dedicated treatment regimens. For patients that survived, re-entry into their communities and survivor support was absolutely essential, and this went along with public health education and community outreach to explain what all was necessary to control and contain and eradicate that outbreak. Initially, and we see this now, the ability to test patients was very limited. When your testing is limited, it's difficult to do the proper identification, and you have to work with just a case definition. Once we get accurate, rapid testing, we can do far more about getting accurate numbers and determining the nature of the outbreak, the true details of who's getting infected, what's the nature of their cases, and who's most at risk. Additionally, how is it spreading? Once we have widely available testing, it's much easier to gather that data and move the response along. With Ebola, the treatment at the time was all supportive, and that's similar to now. We know how to implement aggressive supportive measures that allow the body to support itself so its immune system can fight this infection. With that said, currently there are 2 case-controlled phase 3 trials for antiviral medications taking place in China now. That's incredible, the speed at which those studies were implemented, and we'll hopefully be getting constructive clinical data from that. It's just astounding knowing that the world's alert to this was just over 2 months ago. So let's move to coronaviruses. We could talk about COVID-19, but I actually want to spend the most time on SARS. Our first large-scale novel coronavirus was SARS, and then was followed by MERS-CoV. They follow a similar pattern. We think that this could come from animal reservoirs, particularly bats. With SARS, we think it was transmitted to civet cats, which were eaten, purchased, cared for in wet markets. With MERS, we think the vector became dromedary camels, and then in both cases, we started to see the emergence of human-to-human transmission. In this case, we think we've got this. We know that this was likely related to a wet market, likely from bats, potentially to snakes, and then to humans. The pattern is very similar. When you read the stories from SARS, it's like tracking the daily situation reports for COVID-19. There's dense, thick reading that can be done. The Ontario Provincial Report titled The Spring of Fear and the Institute of Medicine's report on SARS both read like reading the daily situation reports for COVID-19 that are on the WHO and CDC websites. So let's draw some direct comparison with some of the chapters from the SARS story. The virus development in the wet market seems very similar to what we're hearing today, going from critters to humans in a highly dense environment. Movement, mass human movement related to the Chinese New Year. SARS started in November. This outbreak seems to have started in November and spreads rapidly towards the end of winter into the spring. That's, I think, what we're going to be watching here. There are certain instances in SARS when the holes of the Swiss cheese came into alignment. There was a large housing block in Hong Kong that became the nidus for infection because of compromised plumbing, and a whole tower that had dense case numbers. Similarly, the Hotel Metropole, the place I've been, it's now named the Q Green, became a small center for what became international transmission, and I want to share a particular anecdote about that. Hospitals and nursing facilities in Toronto were the centers for nosocomial transmission and the spread from patients to workers and back to patients. With what we're seeing currently, the cluster of cases in Washington related to a nursing home, it does raise some similarities there. In SARS, there were debates about case definitions and what infection control measures and PPE were necessary. I think we've moved past that, and I hope that we don't struggle with that in the same way they did during SARS. Admittedly, and in an anticipated way, there was massive public fear. People were fearful for their families. They didn't know if they should go to work. They didn't know how this would end. And I think we see some of those same themes coming up right now. And to jump to one of the punchlines, I think we combat fear, natural, understandable fear, with high-quality information. The nursing home cluster seems like a similar story as what was seen in Toronto. Now, what we didn't see then, and will be a special chapter for this outbreak, is the role of international cruise lines. Seems like an evolving story right now, and I'll be interested to see how history looks back on that. So let's talk about the international transmission. There was a doctor from China who went to a family event in Hong Kong. He stayed in the very nice Metropole Hotel on the 9th floor. Stayed for a few days. He was ill. He interacted outside of the hotel, but largely self-isolated. This hotel became the source of 19 other infections. No hotel staff were infected, but individuals from Hanoi, Singapore, and Canada became infected. Some of them transmitted the infection to others. Some of them took it across borders. Some of them didn't transfer the virus to anybody else. That transmission pattern is still not completely understood, and that floor of the hotel has been studied up and down. What surfaces were touched, the flow of the air throughout the corridors, and the positions of the guests within their rooms, which were adjacent and which were completely separated, and how this person, this physician, didn't have contact directly with many of them, but still many got infected. So, from Hong Kong, from the hotel, we see a very interesting event. And I call this the Canadian contrast. Someone who was asymptomatic at the time, who went on to become very ill, got on the plane from Hong Kong and flew home. She was elderly, she'd been visiting relatives in Hong Kong, and she went on to die at home. But not before other family members who had cared for her got sick. One of her sons went to an emergency department in Toronto, spent 16 hours in the emergency department, infected 2 other patients, and from there, the city of Toronto had what's known as SARS Toronto occur. On the same day that that patient's son went to the emergency department in Toronto, 2 people got on a plane from Hong Kong to Vancouver, an older couple. Both of them had SARS. No one transmitted the infections on the airplane, but they got home. The wife was ill, but convalesced at home and self-isolated. There was no further cases from her. Her husband was ill also, and later became critically ill, but survived. He went to Vancouver General Hospital. He was admitted to the ICU and treated there. There were no further cases. What was the difference? That hospital had taken the standard approach that until they knew what the cause of the infection was, they would stay one standard higher for their infection control measures until they knew exactly what they were working with. So they had isolated him, established aggressive respiratory precautions, and kept their staff safe and kept other patients safe. This is what I call the Canadian contrast, and I think there's very valuable lessons in infection control from that story. Another, I think, important clinical anecdote from SARS is the impact of deep respiratory procedures, endotracheal intubation, suctioning of patients who are on a ventilator. In fact, difficult intubations were described as, quote unquote, like a mucus gun. We also saw that 1 in 4 of the SARS patients treated in Toronto, those that went to the hospital and were ill, required intubation. You can think about that as important from a resource rationing standpoint and what we have available to us. We also saw that after intubation, there would be spikes in the number of healthcare workers, those in the room who got infected, this mucus gun. The World Health Organization produced a training video with a robotic simulation model. Prior to intubation, they rubbed an invisible gel around the mouth and chin with a UV marker in it. The patient was intubated in standard fashion, and the lights were turned off afterwards, and a UV light was turned on. The first words out of the laryngoscopist's mouth were slightly off color as they started to recognize where all over the room and all over the caregivers there were blue speckles. They were on the providers, they were on the wall, they were on the equipment. They looked around, they'd never seen anything like it. From this, the recognition that people performing these procedures were getting sick and these implications, they actually took some aggressive steps to change the procedures for intubation. And I think that this is worth considering. Intubations were performed with only 3 people in the room, 1 nurse, 1 respiratory therapist, and the most skilled laryngoscopist or intubator available. And they wore full PPE, including PAPRs. The procedures changed. The infection control procedure was adapted, and the number of cases that were created during these procedures dramatically dropped. The other thing we saw in SARS, and I want to have considered now, is the role of interfacility transfers from inpatient units to nursing homes and hospital-to-hospital transfers. They saw an increase in nosocomial transmission, and you might have one hospital that had cases, and then accidentally a patient transfers from that hospital to another hospital, and then you have other staff members and other patients getting sick. If we start to see widespread COVID-19 community transmission, I think we need to think very carefully about how frequently we transfer patients from institution to institution and what kind of screening takes place before this occurs. We will potentially face a genuine staffing conundrum. They did in SARS Toronto. Caregivers, support, and ancillary staff want to care for their patients and feel a genuine responsibility for this. They're also facing a genuine fear of new and uncertain situation, potentially new ways of treating people with increased infection control procedures. That doesn't usually scare providers away from what they see as their duty. What creates conflict internally for individuals is fear of bringing infection home. And it's our responsibility to provide as much high-quality information so that our nurses, our physicians, our support staff can feel like they will be protected. They have faith in these procedures. We know how to prevent the transmission of infection, and we can provide the right personal protective equipment. Still, at the time of our greatest surges, we will face other challenges. Some staff may be quarantined. Some will arrive to work feeling well, but actually be carrying the virus. Some will want to work even when they're sick. Some will need to stay home to care for others or provide child/daycare if schools and institutions close. All of these at a time of large patient surge are challenging. I don't have the silver bullet. I do think that individual institutions can be doing aggressive planning and making contingencies for how they would scale their staffing, change shifts, potentially cohort treatment teams and patient groups to best utilize infection control procedures and personal protective equipment. With this said, I'm going to pass along some stern and somber warnings. These are my opinions. I hope you appreciate their logic, but I need to be clear, these are my opinions. One of the things that will help us control this outbreak is approaching personal protection and infection control with missionary zeal. We can't be too adherent. We can't be too disciplined. We need to be motivated both for ourselves, our patients, and our families, and our colleagues. We check each other. There is a potential leadership moment within hospitals to identify the systems, how we're going to educate each other, and adherence to these measures that will provide confidence that we can do this properly and people can be safe in the hospitals. But it takes dedicated messaging, training, and consistent information from healthcare leaders. As I emphasized before, I think we should look at how we perform invasive respiratory procedures, potentially limiting who's in the room and maximizing their PPE to prevent the spread amongst practitioners and to other patients. We'll need to consider limiting interfacility transfers for COVID-19. And I'll say this kind of firmly. Each hospital is required to meet the same CMS and Joint Commission preparedness standards. I can foresee 2 reasons why a COVID-19 patient might need to be transferred. The first is to a higher level of critical care. And with that said, a case-by-case determination needs to be completed to say, would this patient really benefit? Or do we need to accept that we've maximized the limits of the critical care, whether you're at one facility or another facility? What do we hope to achieve by transferring to a different ICU? The second one, and I'm sympathetic to this, is if an institution had a breakdown in their supply chain or their ability to complete the infection control procedures that would be necessary to keep staff safe. The caveat that I would say is that fear is not an indication for patient transfer. Fear amongst staff, fear amongst other patients should be addressed as a leadership moment. If I could make some predictions, and these are not really bold, over the next several weeks, I think we're going to see a dramatic increase in the number of confirmed COVID-19 cases in the US in particular, whereas other countries kind of seem to have plateaued or might start to go downward. The increased ability to test that is being actively instituted now will provide us with a much more accurate demonstration of what is currently happening. This is good. This provides us a better understanding of the outbreak and shouldn't be viewed as scary. We need to be looking forward within our hospitals and our health systems for what our near future needs are going to be. We need to increase capacity, both room capacity and our remote care capacity, and that might be done purely by telephone or video telemedicine. We'll likely need to limit elective procedures to maximize inpatient capacity. We should be taking this opportunity now to be reviewing and coordinating our regional crisis standards of care and planning a method to cohort both patients and staff to maximize utilization of infection control and personal protective equipment. Every hospital administration needs to be looking at the upcoming staffing challenges if this virus becomes more widespread throughout the communities. I want to share some valuable resources that are available to everybody and are rich with information. The Johns Hopkins Center for Health Security recently released a document titled "What U.S. Hospitals Should Do Now to Prepare for COVID-19 Pandemic." This is a script, it's a checklist, it is excellent, and every hospital incident command center, healthcare administration should be checking the boxes from that. Similarly, we should all be tracking both the CDC and World Health Organization situation reports. They're updated almost daily and contain essential information. The Hopkins document also references something that I think is very useful, and this is the CDC Flu Surge 2.0 document. This is a hospital preparedness tool that helps you identify, based on the size of your institution and your resources, how you can be best managing your resources. If your hospital hasn't already activated a command center, an operations center, it needs to. It's time to have your hospital incident command system up and running and preparing for all the moving pieces that are taking place now. This is the way we establish healthcare coordinated command and control. Related to this is also the close coordination that should be taking place with our county, state, and federal public health entities. And finally, we're close to our families, but I want you to be also married to your infection prevention and control professionals in your hospital. They're the experts in this. They know your institutions up and down, and they will know the resources that you have and how to best implement them. Please listen to the advice of your infection prevention and control professionals. And in summary, I would say, as much as this feels like we're facing a daunting situation, we've got resources, we've got lessons, we've been down this path before. There are methods that we can use to prevent the transmission from person to person, and we can keep our staff safe, which means keeping our patients safe.